mammary tissue functions as a highly sensitive endocrine receptor. From puberty through menopause, the glandular tissue expands and remodels in response to the continuous ebb and flow of steroid hormones. Welcome to Chapter 36, the breast. Our focus here is understanding this tissue's role as a primary target for female reproductive hormones and how that biological reality drives clinical practice. Because of this extreme endocrine sensitivity, the breast is subject to constant metabolic changes. Some of these are normal physiological responses to the menstrual cycle, while others indicate developing pathology. For the clinician, these changes present as a wide variety of symptoms. First, palpable masses, next, localized pain or fluid discharge. The physician's task is to decode exactly what those physical signs mean. These symptoms require systematic evaluation. Sometimes they represent isolated, breast-specific issues. Other times, they must be correlated with findings from the wider reproductive system, like ovarian function or hormonal therapies. Establishing this baseline is necessary to differentiate between harmless, hormone-induced physiological shifts and aggressive malignancies. We begin with fibrocystic changes, the most frequently encountered alteration in breast tissue. Clinically, this presents as diffuse, lumpy textures caused by microcysts and epithelial hyperplasia, an overgrowth of the cells lining the ducts and lobules. On its own, fibrocystic change is benign, but if a histological exam reveals atypical hyperplasia, the clinical picture shifts. That specific cellular irregularity increases the patient's risk of developing breast cancer fivefold. Moving from diffuse changes to solid masses, we frequently encounter fibroadenomas. These are highly mobile, clearly defined, benign tumors that typically appear in younger, premenopausal patients. Look at this clinical photograph, figure 36.1. This illustrates a giant juvenile fibroadenoma in the right breast. Despite its size and the distant asymmetry it causes, the underlying pathology remains benign and is often managed with observation or straightforward surgical excision. Contrast this with phylloids tumors. While they can mimic fibroadenomas histologically, phylloids tumors have a local recurrence rate of 20 to 35%. Consequently, clinical guidelines mandate they be treated as sarcomas. Not all masses are solid. Cystic tumors present a different challenge. Because a tense, fluid-filled cyst can feel identical to a hard, solid mass during palpation, physical examination alone is insufficient for a diagnosis. This ultrasound scan, figure 36.2, shows how we confirm the diagnosis. The anechoic, dark regions clearly visualize multiple cysts, allowing the clinician to immediately distinguish them from solid tissues without an invasive biopsy. While fibroadenomas and cysts are structurally harmless, their physical presence mimics malignancy. This overlap is why strict, protocol-driven imaging is required to rule out cancer in every palpable mass. Beyond tumors, the breast is susceptible to inflammatory conditions outside of pregnancy and lactation, such as chronic mastitis, fistulas, and localized abscesses. Figure 36.3 shows a severe clinical manifestation, a lactation-associated abscess. Notice the erythema and tissue distension. This requires immediate drainage and antibiotic therapy. Another major non-tumor symptom is pathological discharge from the nipple. The first clinical step is always categorizing the fluid. We must determine if it is serous, milky, or bloody, and whether it flows from one duct or multiple. A spontaneous, bloody discharge from a single duct is a clinical red flag. This presentation is indicative of an intraductal papilloma or an underlying intraductal carcinoma. Mastalgia, or breast pain, affects up to 70%. Diagnostically, we must classify this pain as either cyclic, meaning it correlates with the menstrual cycle, or non-cyclic, which can point to specific structural pathologies. Mapping these specific symptom profiles, whether it is the nature of an acute pain or the color of a discharge, directly dictates the algorithm a physician uses to select the next imaging or testing step. Statistically, a woman faces a 12% baseline lifetime probability of developing breast cancer. It is the most frequent malignancy in women and the second leading cause of cancer death. Genetics drastically alter those odds. If a patient inherits specific mutations in the BRCA1 or BRCA2 genes, their lifetime risk increases to between 40 and 85%. At the cellular level, hormone receptors dictate the tumor's behavior. over 50% of malignant breast tumors are estrogen receptor positive, meaning the cancer cells actively bind with circulating estrogen to fuel their growth. Testing biopsy samples for these receptors is clinically mandatory. The presence of estrogen or progesterone receptors determines whether targeted hormonal therapies will be viable weapons in the treatment plan. This mammogram, figure 36.5, shows a dense malignant mass. It's our primary diagnostic tool, detecting tumors under 5 millimeters. But mammography has limits in dense tissue. Ultrasound, figure 36.6, is a mandatory supplement, providing cross-sectional clarity to distinguish solid masses from cysts. To standardize these imaging findings, radiologists use the BI-RADS classification system. This scale ranges from Category 0, indicating an incomplete test, up to Category 6, which denotes a biopsy-proven malignancy, creating a universal language for patient management. Ultimately, imaging alone cannot diagnose cancer. Its purpose is to guide the clinician to the final step of the diagnostic triad, the tissue biopsy. This radiograph, figure 36.7, shows how we target non-palpable lesions. A wire guide is inserted under imaging control directly into the suspicious mass, ensuring the surgeon removes the exact tissue required for histological examination. This is the diagnostic triad, integrating the patient's clinical history, evaluating the BI-RADS imaging, and performing a histological biopsy. It is the only acceptable standard of care for confirming malignancy. Once a biopsy confirms cancer, pathologists categorize the tumor. The disease typically originates either in the epithelium of the ducts, known as ductal carcinoma, or in the terminal lobules, classified as lobular carcinoma. Look at Table 36.1, the UICC-TNM staging system. This framework dictates all surgical and medical treatment decisions. Stage is calculated by combining 3 variables: T for tumor size, N for lymph node involvement, and M for distant metastases. Historically, treatment meant the radical Halsted mastectomy, removing the breast, underlying muscle, and axillary lymph nodes. Today, the standard has shifted toward breast-conserving lymphectomies, paired with the targeted removal of just the sentinel lymph node. Surgery achieves local control, but systemic control requires adjuvant therapies. Depending on the tumor's profile, patients undergo radiotherapy, chemotherapy, or receptor-targeted treatments like tamoxifen. These protocols must sometimes adapt to complex clinical scenarios, such as breast cancer presenting during pregnancy or lactation, an event that occurs in roughly 1 to 3 out of every 10,000 pregnancies. In pregnant patients, the protocol is highly specific. Surgical intervention is generally safe during gestation, but to protect the fetus, chemotherapy is delayed until after delivery. Clinical mastology has evolved from blunt, aggressive surgical excisions into an algorithmic science. By integrating genetic profiling, receptor status, and precise imaging, clinicians can now deploy targeted, tissue-sparing care.